Welcome everybody to this free paper session 2. Today I like to present you a follow-up report of treated breast cancer patients. The title of our topics is Temporal Measurement of Death of Treated Breast Cancer Patients based on pathological lymph node stages of tumor node metastasis classification of American Joint Committee on Cancer. Current trend of T1 and T2 breast cancer surgeries are to conserve axillary lymph nodes. This is explained as one or two positive nodes of sentinel lymph node biopsies showed same overall survival as that of axillary lymph node dissection, according to American College of Surgeons Oncology Group Z0011 randomized clinical trial of 2017. Furthermore, 2 or 3-field lymph node dissection in esophageal, gastroesophageal junction and other cancers indicated with definite prolongation of disease-free survival as well as overall survival. Pathological end stage of TNM classification is designed to forecast outcome of treated breast cancer patients, but it counts absolute number of positive lymph nodes only. In fact, number of axillary lymph nodes has wide variation in humans, ranging from 5 to greater than 30. Thus, counting number of positive axillary lymph nodes only might not express true progression of breast cancer. These studies compared death distribution and survival function estimation of treated breast cancer patients between pathological end stage and lymph node ratio categories. Materials and method. This prospective cohort study was conducted on 51 diagnosed breast cancer patients. Data was collected between August 2016 and December 2019. It was 24, intermediate risk LNR was 19, and high risk LNR 8 patients, about double than that of pathological node stage. And the difference is highly significant between these two groups. Follow-up results according to December 2022. Overall duration of follow-up, median duration of follow-up was 55.3 months, and overall disease-free survival was 51.11 months, and overall survival was 52.43 months. Duration of survival of death patients. Number of total deaths was 20. Median disease-free survival was 39.6 months, around 40 months. Median overall survival was 46.12 months. Distribution of deaths according to pathological end stage. Pathological N0 deaths, 2 deaths out of 13. Pathological N1, 3 deaths out of 16. And pathological node 2 stage, 12, maximum death in pathological end stage. And pathological N3 stage, only 3 out of 4. Difference was significant. According to LNR category, death distribution was low risk LNR 6 out of 24, intermediate risk LNR 6 out of 19 patients, and high risk LNR 8, that is same percent death out of 8 patients. Difference was highly significant. Survival function of DFS, according to Kaplan-Meier survival function estimates. We observed in pathological end stage, the pathological N3 curve is discordant. That is, it is not not in harmony with the other three curves, and it directly crosses other three curves. And the pathological N0, N1, N2 curves are in harmony and with similar survival function. And also survival function of LNR stage, disease-free survival. Here we observe low and intermediate risk LNR group has similar survival function, and there are some overlap indicating at that point survival function was same, and the high risk LNR almost all the deaths were at an early stage of follow-up, and the gap between high risk LNR and other two is discrimination. There is well-defined discrimination between the three curves. And same and overall survival cases, survival function of pathological N stage indicates same discordant curve of pathological node 3 stage with the other, and in LNR group, overall survival same as that of disease-free survival. Discussion. This is a small-scale study, but exploratory in nature. However, findings deserve more large-scale research. Follow-up studies continuing. Conclusion. Significantly higher number of high-risk cases of treated breast cancer patients were identified in high-risk lymph node ratio group, and all died within earlier part of the follow-up. It forecast disease-free survival and overall survival better. However, this type of study require routine axillary lymph node dissection. Pathological axillary node staging could partially predict disease-free survival and overall survival of treated breast cancer patients. Pathological node stage of TNM classification for breast cancer should be modified. This is our suggestion. By adding number of positive nodes and total number of dissected nodes as superscript for easy calculation of LNR and pathological node staging. There is an example. And it is logical that axillary lymph node should be a routine procedure in breast cancer surgery. And we are hoping that routine axillary lymph node dissection will be start soon in developed countries like European and American countries. Thank you very much for giving me a chance to stand in front of you.